So thank you all of you for joining today. This is another LTCcovid webinar. As with previous webinars, remember that this is going to be recorded and we're going to be sharing the video. We will also make the slides available. And I'm going to dive straight in because we have quite a lot to cover today. And I'm going to be sharing the screen. We have an interesting format of presentation today because we're going to be sharing this as a list of questions that we're going to be asking of each of the presenters. And we're going to introduce you to this very soon. So the topic today is on COVID-19 vaccinations and immunity in care homes. And we're going to be here from international evidence and evidence from Chile, the UK, and Canada. And I'm really delighted and grateful to Max Salcher-Konrad, my colleague from LSE, Jorge Browne from the Universidad Católica de Chile, Amy Su from the Bruyère Research Institute and University of Ottawa, and Laura Shallcross from UCL, the Vivaldi study. Before we start, actually, I want to also mention that we have another webinar next week that will be looking more at COVID-19 and long-term care systems, and we're going to have perspectives from France, Italy, and Portugal, as well as an overview of OECD responses. A very different type of webinar because that's looking more at systems, whereas today we're looking at effectiveness of vaccines. So for today, what we'll do is we'll actually divide the webinar in 4 sections. In the first one, we'll have an overview of 4 studies. We will then look at what evidence some of these studies will have or have already on effectiveness of COVID-19 vaccines for people living in care homes. We will then look at what do we know about the duration of immunity, and then we'll have a discussions on the next steps for some of these studies and also implications of what we've learned today for research policy and practice. And we hope to have some time for discussion at the end. So I'm now going to starting this section on introduction to the studies. I'm going to, first of all, invite Max to give us an overview on evidence on vaccine effectiveness in long-term care populations. Floor is yours, Max.
Thank you, Adelina. Right, so my name is Maximilian Salcher-Konrad. I'm a research fellow at CPEC, and I'm working together with Adelina, other colleagues at CPEC, and also colleagues at the Nuffield Trust in the social care COVID recovery and resilience project. And so this this work, which is a very pragmatic review of what we know so far and what evidence has emerged on vaccine effectiveness, is part of that project. Next slide, please. And I will only take a few minutes because I think the focus of this webinar clearly is on the other presenters showing us their original studies, but just to give a bit of a flavor of what types of evidence have been generated so far on vaccines in this population. So we wanted to conduct a pragmatic review, a rapid review of published studies looking at or trying to monitor and summarize what evidence is emerging on COVID vaccines. And so we conducted weekly searches, basically running the same search in one database only from February until just last week, and then also conducted some other searches as well to complement that. So possibly not entirely comprehensive, but we think we captured most of the important stuff. And we simply included original research articles that looked at the effects of COVID-19 vaccines in long-term care users. There is a research letter that was published in JAMDA which summarized the findings as of the 11th of May 2021, if you're interested in that. Next slide, please. So briefly, the types of studies or the types of available evidence that has been generated can be maybe broken down into the following categories. There are very few, really 3 that I'm aware of, population-based studies that estimate vaccine effectiveness. One of them is the Vivaldi study that Laura Shallcross will be talking about. And then there's another study from Denmark that looked at 39,000 residents of long-term care facilities there, which showed that actually after the first dose, there was no protective effect, but that might have had to do with a very short interval between the first and the second dose. And after the second dose, and increasingly as time went on, there was higher protection against infection. And that picture seems to be replicated in another study from Spain, a smaller one, but where the vaccine effectiveness among those who were fully vaccinated, so 2 weeks or so after the second dose, so this is for the mRNA vaccines, was quite good, 71% against infection, 88% against hospitalization, 97% against death. And compared to those who were not fully vaccinated, who only had one dose of the vaccine, those numbers were a lot lower compared to the fully vaccinated. So a very clear picture emerging there. There are some other types of studies that looked at the impact of vaccination programs from an ecological point of view, or looking at institution level outcomes. One of them is a study from the United States in about 22,000 residents, which found that there was a reduction. So basically, once care homes started vaccination clinics, over time, after at least 2 weeks or so after the first people were vaccinated, there was a reduction in incident cases, in new cases, among the people who were vaccinated, but encouragingly also among those who were not vaccinated. So showing that, or aiming to show that protective effect, even for those who weren't getting a vaccine. And similarly, other types of ecological studies also showed lower rates of new infections once vaccination programs started, and sort of after a number, either 50%, 70% of residents have been fully vaccinated. And then the last two categories really of studies are outbreak reports. So there are quite a few reports of outbreaks happening, even though a large proportion of residents were vaccinated in individual care homes. So there are a number of those. And then immune response studies, and I think we'll hear a little bit more about those. So the ones that have been published really are typically single center studies with relatively small patient numbers, sometimes maybe exploring the relationship between those residents who had a prior infection, natural infection, and then were vaccinated, and those who only had the vaccines. I think we will hear more about immune response studies, and of course about vaccine effectiveness, and then also the overall impact of vaccination programs in each of the three following presentations. Thanks.
Thank you very much, Max. So now we're going to hear from Jorge Browne Salas, and presenting some data on the epidemiological status of long-term care facilities with high vaccination coverage and high communities transmission in Chile. So thank you very much, Jorge, and please let me know when you want me to move to the next slides.
Thank you, Alina, for the invitation. I'm sorry for being late. So next slides, please. So I'm gonna do a brief introduction of the epidemiological status of Chile right now. So we have been hit really hard by COVID-19, and since the beginning of this year in 2021, we have in the whole year this second wave that has these 3 peaks, and only recently in the last few weeks, number of cases has been decreasing rapidly. So next slide, please. In terms of the circulating variants in the community, this second wave has been mainly due to Gamma, which is P1 variant. At the beginning of the second wave, we had a bit of Lambda variant, but it's losing terrain against P1 in the last months. So this is basically P1 what we are seeing right now, and we have a few cases of Delta variant, but it's only from travelers, and we don't have evidence yet from a community transmission of Delta variant in this country to date. So that might change in future, but we don't have evidence of that right now. Next slide, please. In terms of the vaccination, at the beginning of the year, we in January of 2021, we began this mass vaccination program, which is mainly with Sinovac vaccine, the CoronaVac vaccine, which is a virus inactivated vaccine. And to date, we have something about, I think it's 58% of the population with second dose, and it is increasing each day. Also, we have around 20% of the vaccines are Pfizer, and we do have also a bit of CanSino vaccine and AstraZeneca vaccine, but those last ones are only I think is less than 5% of the population with those with CanSino and AstraZeneca. Next slide, please. Slide. In terms of this, what the characteristics of the long-term care facilities in Chile, similarly to other countries, around 25% of the population, 65 years and over, have some degree of functional ability loss, but only 1.4% of the population live in long-term care facilities in a mix of public, no for-profit, private for-profit institutions. And this last group of private for-profit institutions have two different subgroups. One, those with the authorization of the Ministry of Health, and those informal or without the Ministry of Health authorization, in which we don't have a clear idea of the quality of care provided in those facilities. But we do know that it's highly heterogeneous. So some of them with really good standards, and some of them with current quality care problems. Next slide, please, Adelina. So, and in relation with the strategy for long-term care facilities, this strategy began early on last year, in 2020, and it was a joint strategy made by the Ministry of Health, the National Service of Older People, or Older Adults, sorry, and the Chilean Geriatrics and Gerontology Society. And this strategy included for all the facilities, included free delivery of personal protective equipment, protocols and guidelines, staff replacements for cases of COVID-19 related sick leave, field testing with PCR, transfer of cases to sanitary houses, and a monitoring platform. The data that I will show later on this presentation is basically the data we collected and analyzed from this monitoring platform. Next slide, please. And in terms of the vaccination of the long-term care facilities, today 87% of the population, which is resident plus staff of long-term care facilities, have been vaccinated 2 weeks after the second dose. And those people is mainly with Sinovac vaccine, and only 4% of them are vaccinated with Pfizer vaccine. We do have some regional differences. So in this graph, you can see the different regions in the country. And this is the graph is only showing residents. And you can see that in some regions, like for example, Ñuble, which is I think that is right in the middle, we have 94% of residents vaccinated, but other regions like Antofagasta, which is the third from left to right, we only have 84% of residents vaccinated. And this is not because of access, this is because of vaccine hesitancy and families having doubts around vaccine and not wanting having the vaccine themselves or for their relative. Next slide, please.
So here we move to Amy, and we're going to hear about the Bruyère study, and then we will come back to the rest of the presentation for him. So now we're going to hear an introduction to the Bruyère study on COVID-19 vaccinations and immunity in care homes. Okay, all yours, Amy.
Thank you for that introduction, Adelina. Next slide, please. So first of all, thank you everyone for attending this morning's webinar, and well, morning in Canada, afternoon for those in the UK. But it's my pleasure to be able to share with you some of the observations that we've had around long-term care sector and the impact in Canada. Next slide, please. So one of the things that I want to point out is, of course, the high proportion of older adults living in care homes in Canada. And this is not, I think, anything that, that is distinctly different from other jurisdictions. But across Canada, around 75%, so almost 75% of the older adult living in care homes, including retirement homes, are over the age of 80. And of course, we know that with concerns and ongoing discussions about immunosenescence and response to the vaccines, this is a highly vulnerable population, which, from the clinical trials data, we have very little information on the immune response that would be observed in this population, which is why we're doing these studies. Next slide, please. Now, specifically in the province that I'm situated in, which is in Ontario, we see that over time, there's been an increasing proportion of individuals who are admitted over the age of 80. In fact, when we look at the data from 2015, over 50% of newly admitted residents into care homes in Ontario are over the age of 85. And next slide, please. And within this population, of course, we know that many of them are living with multiple chronic conditions. So as you can see here, when we looked at the temporal trends of newly admitted residents to care homes in Ontario, you see that steady increase. So there's that line with the triangular marker there right in the middle, that steady increase of individuals with 7 or more chronic conditions being admitted into care homes. And of course, one of the recurring message that we had heard since the start of the pandemic was that individuals who are older with multiple comorbidities are more susceptible to the severe outcomes and mortality from COVID-19 infections. Next slide, please. And so I wanted to set that bit of context, I think going back to what Jorge had presented earlier, is that, there's actually a lot of questions that we're hoping and continuing to explore with regards to vaccination and vaccine effectiveness. So now looking at data in terms of vaccination in Canada, unfortunately, we don't have national level collection of vaccination coverage in care homes. But what this graph shows you is the breakdown by age groups. As you can see, the vaccine program in Canada started around mid-December. In Ontario, the first resident was vaccinated around December 14th. And of course, older adults and individuals who are also, so workers in care homes, were prioritized for vaccination because of the impact of COVID-19 on this sector. And as you can see that by last week, so by July 3rd, 94% of those over the age of 70 have been vaccinated, have received at least 1 dose. And this includes a large proportion of those who are residing in care homes. Next slide, please. And when we look at the coverage of individuals who are fully vaccinated, so who have received both doses, or the full vaccination from a single dose regimen, though that hasn't been rolled out in Canada, we've been mostly being administered an mRNA vaccine that required both doses. So what you see here is that around 80% of this population of older adults over the age of 70 have received both doses of their vaccine. Now in care homes, at least in Ontario, where I have direct access to the data, that proportion is a little bit higher. So in care home, we know that around 95% of the residents have been vaccinated as of early May, and around 85% of workers in care home have received at least 1 dose. So of course, we're still really focused on getting the second dose administered within this environment. Next slide, please. So that's in terms of the vaccine coverage. But I think one of the remaining questions that we continue to discuss, sorry, next slide. I don't know if the slides, okay. So one of the issues that we continue to discuss is, of course, what is the impact of the variants of concerns, the VOCs, on potentially outbreaks that we might see moving from this point forward. And like I presented earlier, a high proportion of the residents in care homes have been vaccinated. But of course, we know that the vaccine, despite their high efficacy, they're not 100% effective against all severe outcomes and mortality from COVID-19. And so what we see is that, of course, with rising transmission in the community, especially when there are individuals in our population who remain unvaccinated, it increases the risk of exposure. So eventually the virus will find its way into care home. And of course, this is a population that are more likely to succumb to the more severe outcomes from COVID-19 infection. So in Ontario, we now see that the predominantly circulating strain is the Delta variant. Next slide, please. In fact, when we look at the latest data that's generated from Ontario, this is where we see quite a different picture from what Jorge has presented earlier, and I think what we'll see from UK as well, that approximately 80% of the newer cases identified in our province has been the Delta variant. So for a while, we did see quite a large circulation of the Alpha variant, and in fact, those were some of the earlier outbreaks that we saw this year in care homes, but now we're seeing the impact of the the Delta variant. Next slide, please. And of course, you know, the reason why we're so interested in this, because we know that they're more transmissible and they're associated with greater impact on healthcare use as well as mortality from an infection. So this is a study that had looked at the data from Ontario. So this is actually generated from the Ontario COVID-19 Science Table, where they've compared the newer cases that have been identified that were associated with one of the variants of concerns to other studies published in other jurisdictions. And we do see that, and this is information that many of you would be familiar with, that individuals who were affected with one of the variants of concerns are more likely to be hospitalized, more likely to be admitted to ICUs. Now, granted that a large proportion of this population that have been impacted by the variant so far has been individuals in the community because of the lower vaccination rate. But we will see, I think this is part of the discussion about what the impact might be on the care home population moving forward. Next slide, please. So I'll just quickly go over the study that I'm involved in. It's called the C19 Immunity Study. C19 stands for COVID-19. Next slide, please. And this is a study that is actually being conducted across several provinces, so several regions within Canada. I posted a link here in case there is interest in the future to look at a promotional video that we had created that summarizes the study. Next slide, please. And like I said, you know, the study objective is to continue to look at continue to explore what are the risk factors that increases the likelihood of future infection, possible reinfections, and also severe outcomes from COVID-19 in both individuals who have been vaccinated, but also those who have not been vaccinated in care homes. And we're hoping to monitor the effectiveness of vaccine in this population for up to 12 months post-vaccination. Next slide, please. So like I mentioned, this is a study that's being conducted across multiple provinces in Canada. Our target is hopefully around 8,000 participants, and that's a combination of care home residents as well as workers. Adelina, I had some animation on the slide. I don't know if that will work. If you just click through, you might see the numbers pop up. Perfect. So we're hoping to collect data from just under 1,000 long-term care or care home workers in Quebec. In Ontario, we're hoping to collect data from about 3,000 care home workers, 1,500 residents, and also about 1,000 designated care partners or caregivers to residents in care home. Of course, many of you would be familiar with the fact that designated care partners and caregivers to residents are often older adults themselves, and they were actually prioritized for vaccination in many provinces across Canada as well. And we're also conducting the study out west in the province of British Columbia, where we're collecting data from 500 care home residents, just about 1,000 care home workers and 500 designated care partners. Next slide, please. So our sample collection primarily consists of dry blood spot cards. So these are dry blood spot samples where individual would obtain a small blood sample from a finger prick, and then they would put a few drops of blood on the filter card that they send back to our lab for processing. And like I mentioned, we're hoping to collect data from over the course of the next 12 months following vaccination. Although there are also individuals who are unvaccinated in our sample, and that's an interesting point for discussion later on. But essentially, we're following individuals in care home over the next 12 months, approximately 3 months apart. So 4 data collection points. And the sample is then sent to our molecular virologic lab at the University of Ottawa. And eventually, our goal is to link this data to administrative databases. So data looking at hospitalization, looking at access to physician visits and physician care. Also additional information that we might have on these individuals collected through various data sets that we have across these different provinces, including information on their socioeconomic status, looking at whether or not they're immigrants. And all this is actually built into the process so we can minimize the data collection burden on care home, individuals in care homes by taking advantage of actually quite a wealthy resource of data that we have through administrative databases in Canada. So unfortunately, I don't have data to show today because we're still working through the interpretation of the results. So I don't want to jump the gun and present results that haven't been fully finalized and vetted by the entire team. But I will, I think later on through the discussion, point to some of the observations that we made and share some of the preliminary findings. Oh, I don't need to present the slide.
Thank you very much. And now we're going to hear from Laura Shallcross from the Vivaldi study in the UK. All yours, Laura.
Thanks, Adelina, and thanks for the invitation. And my background context is going to be rather a lot briefer. So well, let's see how we go. So I'm chief investigator for the Vivaldi study, and we started in May 2020 in a big hurry. And our overarching aim was to investigate infection immunity in staff and residents in care homes in England. Oh, next slide. Yeah, thank you. And so just to try and orientate you a bit. So this graph shows the number of deaths that occurred in care homes in England and Wales in the first wave of the pandemic. So that started sort of February, March 2020, and the second wave, which started in around September. And the first wave, as you know, was driven by Wuhan strain primarily. And then with the second wave, we saw a shift with the emergence of the Alpha variant in the UK. And that was largely responsible for the second wave that we saw. Importantly, care home staff and residents were prioritised for vaccination in England and in the UK. And vaccination started on the 8th of December. And we started off with the Pfizer vaccine, and that was shortly followed by the AstraZeneca vaccine. And the vast majority of staff and residents in care homes in England have been vaccinated. So we're up to over 90% of vaccine coverage. But importantly, in the UK, as you will be aware, the recommended interval between dose 1 and dose 2 for the vaccines is 3 to 4 weeks. But there was a policy decision in the UK at the end of December to extend that dosing interval to 12 weeks. And that was to enable a greater proportion of the population to receive their first dose. So clearly understanding the impact of dose 1 became particularly important for us. We were quite fortunate in the UK in that a whole care home testing programme was set up relatively quickly. So this was piloted from in May and really got going from around June. And what this meant is that everybody in care homes, staff and residents, were being tested regularly. So that was asymptomatic infections and symptomatic infections. Staff were tested weekly, residents were tested monthly. And then on top of that, we had surge testing during outbreaks. So that really is very helpful if you want to look at vaccine effectiveness, because you've got really good data on the number of infections that are coming into your care home. And next slide, please. So, of course, there are so many research questions that you might want to answer, and we all wanted the answer to these as fast as possible. And so starting with the basics, the first thing we tried to answer was to understand what proportion of staff and residents had been infected in wave 1, and then thinking about wave 2. And we were interested in whether staff and residents could be infected twice, because of course, now we have vaccines that seemed less important. But when we started this study, people were worried about, well, was this a case you would get SARS-CoV-2 once and be immune forever, or were we going to see annual peaks more akin to flu? We were interested in understanding what the risk factors were for outbreaks and large outbreaks, obviously vaccine effectiveness, but also really importantly, continues to be important, what's the duration of immunity following both natural infection and vaccination? Next slide, please. And so this is an overview of our study design and a lot of similarities with what Amy's just outlined. So we started off in 100 care homes that were owned by a single care home chain, but we've been able to expand to over 300 care homes now in the last year. And these are distributed across England, across all regions. And there are 3 main components to our study. So we're collecting blood, so venous blood from staff and residents. And we're doing this at serial intervals. And the reason we're doing that is so that we can look at the antibody responses, but also look at cellular immunity, so T cell responses, because obviously you have the innate and adaptive components of the immune system. We've been linking that information to PCR test results through the national program that I just told you about. And we've been able to bring all of this information together in something called a trusted research environment, which is basically a secure data environment. And these samples can all be linked together, samples and data, via individuals' NHS number. And so that has let us also link to these routine data sets that are available in the UK. And so that's things like hospital admissions, mortality data, but most importantly, vaccination status too. And so that's given us a very rich picture of what's been going on in the care homes in wave 1 and wave 2. And we're constantly enriching that data by bringing in more data resources. I should add that all of this has really been made possible because of the governance and changes in data regulations that have been brought in the UK in response to the pandemic. And this would not have been possible over this timescale outside of a pandemic. And we've really benefited from that. So I think that's my last slide, Adelina. This bit. Yeah, thanks.
Yeah, that's right. So now we're going to move to the second part. And we're going to look at the evidence emerging from the 3 countries and studies on effectiveness of vaccines. So now I'm going to invite, we'll start again in Chile. So I'm going to invite Jorge again to tell us about the emerging findings.
So what I'm gonna present now is routine data that we have been collected through the Ministry of Health and analyzed by Senama. As Laura said previously, we have more questions than answers, I think, with these slides, but we'll go through and maybe they will be used later on for the discussion. I think that we have cases, one previous slide, sorry, Adelina. What you can see here in this slide is the 2 curves of cases matched together with different scales, but basically they are used and presented this way to show that in the first wave, we have a good geographical and time match between the incidence of the community and the long-term care residents. The second peak in yellow here is due to a monitoring methodological change. It's not a real peak. So this basically was one big peak. In the first wave, these 2 groups, the community and the long-term residents, were matched basically. And what we saw in this second wave, at the beginning of this first year is that these two curves began to decouple from one to each other. So vaccination started here early on January, and 80% of the residents were fully vaccinated by April. And so in the second wave, we didn't have this huge spike in cases, but at the end, these last few months, we have had more cases that have been increasing, I would say, which is a bit, we will talk a bit, we will do a zoom in that this part of this last couple of months. Next, next slide, please, Alina. We saw also a similar thing with Dept. So curves are decoupled for this this second wave. Sorry. Next, Alina. Thank you. And if we compare what happened before the 15th of April and after what happened on 15th April, which was the date in which 80% of the residents had a complete scheme. Sorry, I think a couple of words are in Spanish. Sorry for that. We see that previously we had attack rates that were around 30–35%, and before that date, attack rate decreased by 10% to 23%. Also, fatality rates decreased from 20% to 11%. Of course, there are many things going around. Not only vaccination has happened around town. Also, we have here a huge bias, that is survival bias. And because after we know that after the first wave, around 40% of the residents were infected. So probably there is a mix of effects around here, but we did have a decrease in case fatality rate. Next slide, please, Alina. However, we still see, and this is from this is the long-term care facilities that have at least one active case of COVID-19, and from March until today, until last week, we have had several outbreaks. We still have outbreaks in long-term care facilities, and this has been a continuing problem. And I want to talk of those outbreaks that we are still having and looking at. So next slide, Adelina, please. Thank you. This is last year this year from January to date. So we are still seeing cases during this wave between 100 and 200 cases each week, and we are still seeing deaths related from COVID around 10 and 20 deaths each week. So of course numbers are lower than other countries, but the population is also much lower. So next slide, please. And this is just, I want to bring just simple examples. Yeah, so these are plain examples of what we are seeing right now. This is a selection of outbreaks that we are seeing, and we did a selection of outbreaks with high attack rate and high vaccination rate. So this is all this long-term, each row is one facility, an outbreak, sorry. And this is basically the summary of the attack rate and fatality rate of each outbreaks. Some of these outbreaks haven't finished yet, so this is a dynamic, these are dynamic figures that might change in future. But basically this, for example, that started in May, that we have one outbreak here with 100% of attack rate, 20% of fatality rates. The third one is, again, 100% of attack rate, 30% of fatality rate, and so on. So the ones that are in yellow, we know that there have been sequencing, and they are gamma variant that is of course is the same that we are seeing in the community. So next slide, please. Same here. there are more. These ones have been more recent ones, but again, we have some of them with case fatality rates between 10 to 30% with high attack rates. The one in green here, we know that is Lambda variant, that is the other circulating variant in the community right now. Next slide, please. Sorry for bringing too many cases, but I want to bring the clear example of what we are seeing right now. And again, here, even more recently, outbreaks with attack rates 100, 83, 60, 70%, and again with a case fatality rate of some of them higher than 20%. Next slide, please. So those outbreaks that we saw previously are with Sinovac schemes, right? So one question is, have we had any outbreak with Pfizer? And we have only, just remember that only 4% of the residents have been vaccinated with Pfizer. And so we only have a few facilities with Pfizer. And we have, this is a recent outbreak that is currently an active outbreak that we have. It's a facility with 89 residents, 91% of them vaccinated with the complete schemes. Also staff was around 90% vaccinated with Pfizer. And we have a recent outbreak in which the attack rate is 31% with a case fatality rate of 7%. And this might change in the future because this is an active outbreak. So this were sadly might change, increasing the fatality rate. We hope no, not true, but probably it will happen. Next slide, please. So
thank you, Jorge.
In summary, just to make a summary, we haven't analyzed this data to bring numbers of effectiveness, but we are seeing some outbreaks with high attack rate, high mortality, and those outbreaks that we have seen is basically only in the last few months. And so even we acknowledge that we have a huge difference before and after vaccination, we do have these outbreaks that we are worried and bring questions for the future. So probably there will be questions later on, so I'll leave it there. Thank you, Adelina.
Thank you very much, Jorge. And we'll invite you to speak again later when we talk about the next steps and implications of what we are finding out. Now, Amy, you're going to take us through, I think, some emerging findings. Let's see.
Thanks, Adelina. Next slide, please. So I actually realized that I should have mentioned earlier that the majority of the residents in care homes in Canada have been vaccinated with the Pfizer vaccine. In fact, that's the vaccine that majority of Canadians have received to date. So it's a very different situation than I think what is happening in other regions. And actually, I'm really excited to hear Laura's results, because I know the situation in the UK, the AstraZeneca has been administered to care home residents, whereas in Canada, it's continued to be focused on individuals in the community. Now, there's of course discussions about no longer administering the AstraZeneca vaccines in Canada. But what I want to present here is more of the population's perspective, because we don't have the details of data from our study yet. But at the population level, we see that from the start of the vaccine rollout, there was a fairly immediate effect that even though the cases in the community was rising actually concurrently at the same time, we do see that the number of cases within care homes had declined at a much faster rate than the rate in the community. And in the community at the time, there was very little rollout of the vaccine. And so, of course, when we went into the third wave at the end of 2020 and the beginning of 2021, essentially following the opening of the economy just before the Christmas holidays, we really saw that rise in cases in the community. But because the vaccine rollout was happening concurrently, we do see that the impact on residents in care homes was actually significantly lower. So in this analysis, when the scientists in Ontario had compared the projected rate of potential cases in the community, looking at individuals who are over the age of 70, residing in the community compared to residents in long-term care. So those in the community is in the orange line there. The residents are in the blue line there. You see that the cases among care home residents was actually much lower. And the same with healthcare workers as well. You see that, despite the slower uptake of vaccines among healthcare workers, we did actually notice that immediate impact on this population. Next slide, please. So what you see here, what I actually wanted to highlight was that there actually was a rise in number of cases. If you kind of could recall from the earlier slide I showed around the variants of concern. So between the end of March to end of May, early June, the predominant circulating variant in Ontario was the Alpha variant. So as you can see here, there was actually that rise, that corresponding rise in cases in care home residents as well as staff. And by this point, by end of March, the majority of care home residents had received both of their doses. So in contrast to actually quite a few other jurisdictions, Ontario had prioritized the vaccination of care home residents and workers according to the original recommended regimen. So most individuals actually receive their vaccine, their second dose, within 21 to 28 days of their first dose of the vaccine. So it's a very different situation from many other regions. And you really do see that it has, at the population level, had an impact on the severity of the disease as well as mortality. So next slide, please. So despite that rise in cases, we actually see that, within that corresponding period, there had been very, very few deaths among care home residents. Now, I want to emphasize that, I think going back to Jorge's point earlier, that, it's not that there weren't any deaths. And in fact, among vaccinated individuals, we are still seeing cases as well as a few cases of mortality in individuals who have received both doses. And, coming back to my earlier point about the fact that, as effective as these vaccines are, there remain some individuals who are not protected. And in fact, in our sample, we see that about 12% of the individuals who have received both doses do not generate antibody response to the vaccine. Now, of course, I know Laura is going to talk about more details about that data. And of course, like in our study, we're just looking at humoral response, which is antibody response. And there's also, the discussion about T-cell response in the level of protection that it offers. But, some of the earlier finding we see is that, there are still individuals who are susceptible to the severe outcomes of COVID-19 infection. And that's what we're hoping to continue to explore in our study. I believe that's my final slide for this section.
Thank you very much, Jamie. And I think now we've moved to Laura's presentation, I think.
Yeah, that looks familiar.
Yeah, thank you.
Yeah, thanks. So what we have done, what we set out to do in this part of the Vivaldi study was to estimate vaccine effectiveness in residents after first dose vaccination. And the reason we're focusing on first dose is because, as I mentioned, we had this policy decision to extend the interval between dose 1 and dose 2. So our work to evaluate post dose 2 is ongoing. And so the way that we've done this is we have taken data from people in different time periods, pre and post vaccination. So vaccination began in the UK, as I mentioned, on December the 8th. Pfizer first, swiftly followed by AstraZeneca. Care homes tended to receive one or the other, so vaccination was rolled out quickly, usually within the space of 1 to 2 days. And so what we did was we looked at the number of PCR confirmed infections in unvaccinated people. And then once people got vaccinated, we counted the number of PCR positive infections in people in time periods post their first dose. So 0 to 6 days, 7 to 13 days, and so forth. And we use Cox regression to do this, for those of you who are interested, adjusting for a range of variables, but most importantly, adjusting for whether the individuals had prior natural infection, and also adjusting for the local incidence of infection in the area surrounding the care home. Next slide, please. Okay. So onto the characteristics of residents to start. So we were able to enroll or collect data from over 10,000 residents. The median age was 86 years, so reflects very much the care home population and predominantly female. Around 11% had evidence of prior natural infection. So this was either based on antibody testing where available or based on prior PCR test results. Almost certainly this is an underestimate because we know that there was very limited testing at the start of the first wave. However, encouragingly, our residents had a mean of 1.6 PCR tests per month during our study. And so that accords very well with this monthly testing program, and then laying on surge testing on top of that for outbreaks. Most of our testing was in people who were asymptomatic, again, reflecting the testing program. And during the study period, around 88% of our residents were vaccinated, and 2/3 received the AstraZeneca vaccine, the ChAdOx1. Thinking about the characteristics of the care homes, so we had data from 310 care homes. I think in common with the other speakers, we have a real mix of different kinds of care homes in England. It really isn't one size fits all. And so we were able to include a variety of for-profit and not-for-profit care home chains, so that's large groups of care homes. But we also included a smaller number of independent care homes. So we had a reasonable mix of the different characteristics. And as I mentioned, we were interested in knowing whether there were important differences between care homes that mainly got AstraZeneca or Pfizer. And to cut a long story short there, we found that those that mainly got Pfizer were slightly larger and they tended to get vaccinated slightly earlier, but otherwise they seem to be pretty comparable. Next slide, please. So on to the main results. So this is the adjusted hazard ratios comparing the hazard, so the risk of PCR positive infection in people different time intervals post first dose vaccination relative to the unvaccinated group. And I think the box has shifted a bit here, but what you should see is that from 28 days onwards, we start to see a statistically significant protective effect of first dose vaccine in residents. And so around a 56% reduction in your risk of being PCR positive at 28 days, and that's across both vaccines, and that rises to a 62% protective effect at 35 to 48 days. And beyond 49 days, this effect, the protective effect, is no longer significant, but we think this largely reflects the fact that we had less follow-up time from 7 weeks onwards. So our study period ran to March the 15th. And so with more follow-up time, we would be able to be more certain about those estimates. Next slide, please. What we also looked at, and we were particularly interested by, is what happened to the cycle threshold values for people who tested PCR positive. And so cycle threshold is a marker of how infectious somebody might be. And so what we were able to do, each dot here represents a PCR positive sample from individuals. We compared the mean threshold value in people who were unvaccinated to people who were PCR positive post-vaccine, but in the early post-vaccination period, 0 to 28 days, when we think the vaccine isn't protecting yet, compared to post-28 days when we think it is having a protective effect. And if you look at the horizontal lines here, you can see that they are very similar for unvaccinated people and people in that 28-day period post-dose 1, but beyond 28 days, we start to see a difference that's statistically significant. And this suggests that if you become infected and you're vaccinated 28 days onwards, you are less likely to spread infection compared to somebody who becomes positive but is unvaccinated. So overall, this suggests that vaccines are protecting people in two ways. So they reduce the total number of people who get infected, but they also make it less likely that you will spread infection if you do get infected. Next slide. I think that might be the, okay. So to summarize, in residents, we find that first dose vaccination, so Pfizer, AstraZeneca, protects for at least 7 weeks. Vaccinated individuals are less likely to spread infection compared to unvaccinated individuals who become infected. We can have pretty good confidence that the vaccines, Pfizer and AstraZeneca, are working well against the Alpha variant, but we can be a lot less certain about the other variants, certainly in this study, because these other variants weren't circulating in care homes when we did this analysis. And of course, we need to do more work to look at the effectiveness of the second dose, and very importantly, the duration of immunity. I should also add that we looked at the effects of Pfizer versus AstraZeneca, and we found overall the two vaccines were pretty comparable at 35 to 48 days. I think it was 68% in AstraZeneca and 65% for Pfizer. But we did see that in that 49-day period, Pfizer seemed still to be protecting, whereas AstraZeneca didn't. And we think that's probably because of the difference in follow-up time in those groups. So I'll stop there.
Thank you very much. And I'll stop sharing slides for a moment. And I just wanted to see if there's anybody who has any questions on what we've heard so far, and also to the speakers, if you have any questions for each other, maybe now is the time before you forget. So, and I think it's fascinating to see these studies at different stages, but also on different countries, different vaccines, different variants. And I just wanted to thank you all, because I also have written quite a lot about how all of this is working and playing out in the different countries. So anybody has any burning questions now, or any of the speakers of each other, just can raise a hand or unmute directly.
Hi. Hi.
Go ahead, Maria Aurora from Malta.
Hi. Primarily, thanks so much for such an interesting presentations. Just one curiosity. Prior to coming in for this webinar, I was reading that Israel are in the process of giving the third jab to immunosuppressed individuals. Is the UK, Canada, and Chile considering such jabs for the older person cohort within long-term care? Thank you.
Would either of you like to answer this one? Are there any plans in your countries? We can perhaps briefly ask each of you. So Jorge first.
Thank you for the question. The answer is yes. Considering we don't have a clear program or dates of those yet, but health officials are talking about the probable need of a third dose. So I don't have more information about that, but it's something that the country is considering.
And Canada, Amy?
Yeah, so Maria, that's an excellent question. It certainly has been a discussion. I think majority of the Canadian provinces have taken the approach of trying to minimize community transmission, because we know it poses a risk to care home residents, right? So I think the focus has been getting that second dose for individuals and community, but certainly I think the findings from these studies will inform whether or not a third dose is imminently needed. You know, the other thing is that interestingly, there were a couple of residents in our study who had received 3 doses, which is by accident. But we're exploring those results. So there might be some interesting findings there that we will be able to share shortly.
Laura?
Yeah, so I think it's definitely being considered. I'm not aware of any concrete plans yet, but I probably would be the first to know. What I would say is that I think a really important finding that's come out in our study is about natural infection and vaccination. So it's very clear that people who've had natural infection and are vaccinated have the strongest, best levels of protection. And so I think it would be valuable to, if we are going to revaccinate, to be able to take account of that too, because it may be that not everybody needs to be vaccinated 3 times. Yeah.
And I think that's a very nice link to the next part of the webinar, where we're going to look at duration of immunity and the emerging evidence on this. Now, I noticed in the chat, there's an emerging discussion on mandatory vaccinations. Now, this is not something that we're going to be tackling today at this webinar, but we have a paper in LTCcovid where we looked at what different countries were doing and the evidence around approaches to try to increase uptake of vaccination by staff. I will share the link in the chat. And I do think this is a really important topic. I do think LTCcovid is a good place to discuss that, but perhaps we'll tackle this on a different webinar than today. But I appreciate the thinking and the questions, and we will approach them. So I'm now going to go back to sharing, because we do have still a bit more material to cover and look at the question of duration of immunity. And here we're mostly going to be hearing from Laura, because I think the other studies are beginning to look at this. So I think, Jorge, in your case, this is something you'll be looking at?
Really short, thank you, Adelina. Just this is an ongoing question. I think we don't have the clear idea. Probably the last outbreaks that I showed before open this question about how is the immunity 6 months after vaccination, and we are this is a clinical study that will be conducted in the next few weeks for looking at the level of immunity of both residents and their staff of care homes. So probably we'll have more information in a couple of months.
Thank you. And Amy?
Yeah, so we are also in a similar situation. I think one thing that is really interesting about the way that our data or our study has rolled out is that we have a mix of individuals who are newly admitted and were just vaccinated because there were community members coming into care homes and haven't received their vaccine yet. And also individuals who were vaccinated last December. So they're now about 6-7 months from their first dose. So hopefully within the next coming weeks, we'll be able to offer some clues as to the duration of immunity comparing individuals at different time points from their vaccination.
Thank you. And now Laura. Yep, so I should add, we definitely don't have the answers on this one, but we have tried to answer or start to answer the question. So before vaccines, one of the key questions was about whether people could get COVID twice. And so from around November last year, studies started to emerge in healthcare workers, hospital-based healthcare workers, suggesting that people with antibodies were less likely to get a second or to get a new infection. But there were no equivalent studies in care home residents. And of course, here the worry is that older adults are likely to have age-related changes in their immune responses. So we partnered with one of the big care home chains in the UK, Four Seasons Healthcare, and we did blood sampling in 100 care homes quite early on in the pandemic. So June, July, just after wave 1, June, July, and then again, August, September, October, November, and tested their blood samples for COVID antibodies. And this was antibodies to nuclear capsid. Next slide, please. So to try and explain a bit about how this worked. So again, this shows the number of PCR positive infections in our cohort. And what you can see is the relatively small first wave compared to the second wave, which does not reflect what actually happened, but reflects that the limited testing capacity that was available in care homes in wave 1. And what you can also see is a lot of the samples in wave 1 were yellow, which means that we don't know if they were from staff or residents. So again, it just reflects that it took some time for testing to ramp up and for us to be in a position where we had good quality data. So we then see the positive PCR samples going into wave 2 from around September onwards. And so what we were able to do by blood testing people June, July onwards was to determine of those who survived, who was antibody positive and antibody negative. And so we knew about prior infection And we then followed those individuals up into wave 2 to see who got a new PCR positive infection. Next slide, please. And so we did this for staff and residents, but focusing on staff. So overall, we were able to recruit 680 residents, 1,400 or so staff. And the first finding was just the very high proportion of people who had antibodies. And so the majority of these individuals were infected in the first wave of the pandemic, a third of residents, 29% of staff. But then what we also did was to look at who became PCR positive in that subsequent time period. And so again, we did Cox regression here, comparing relative hazards. But what we found was that if you were antibody positive and a resident, your chance of getting a new PCR positive infection was 85% lower compared to somebody who was antibody negative. So trying to translate that into an absolute scale, it means if you were an antibody negative resident over a month during our study, your chance of getting COVID was around 7% versus less than 1% if you were antibody positive. So very encouraging that antibodies prevent infection. The longest duration, the maximum duration of follow-up in this study was around 10 months. So of course, we don't know how long this effect is maintained for. Next slide, please. So what we also did on a small scale with lots of caveats was to look at the quantitative antibody levels in people who were reinfected and a number of controls. And so the short story here, and I've just presented data for spike, but we saw a similar picture for nucleocapsid, was that we didn't see a difference in the titers of people who did get reinfected and those who didn't. I know other studies have seen a difference, and we didn't see an effect even if we tried to take account of the time difference between when the sample was taken and when the person became reinfected. But the big caveat here is, of course, because we don't have PCR data for the first wave of infection for most cases, it means we don't know when people got infected, and clearly that has a big impact on waning immunity. So we've got lots more to come on this. We've got another paper that's looked at the response, the immune response post-vaccine, that's in shortly will be out in Lancet Healthy Longevity. And we've got a paper that will shortly be submitted that looks at the immune response, T-cell and antibody in residents in the first wave of infection in around 300 individuals. So more on this soon, but it's challenging because of the numbers and the difficulties in getting samples from this population. So just one other finding, something that I mentioned earlier, is this really striking finding about vaccination and natural infection. And so here, this is data from our link group, Paul Moss's group in Birmingham, who are immunologists, unlike us. And so what you can see here is that you can see a very clear response in antibody levels to spike, comparing pre and post vaccine in residents and staff. But if you compare graph A to graph B, the red dots are people who've had a natural infection. And you can see that even before they get vaccinated, their antibody titers are so much higher than people who've not had natural infection. So you see this boosting effect post-vaccine for everybody, but where you start is much, much higher if you've had a natural infection. And so clearly that has implications for revaccination strategies and who should be prioritized. I think that's everything on this, Adelina. Yeah, okay. So key findings are that from our reinfection paper, residents and staff with antibodies are substantially less likely to become PCR positive for up to 10 months. Almost certainly it's longer than that, but we don't have the data. And it's going to be very difficult to look at this over a longer duration now that almost everybody's been vaccinated. You can't really look at it. We see that the magnitude of vaccine-induced immunity is much higher in people with natural immunity, and it's hard to get good data on the immune correlates of protection because of sample size and the fact that we don't know when people had their primary infection. hopefully this question around waning immunity will be easier to answer following vaccination because we know when people got vaccinated. I'll stop there.
Thank you very much, Laura. And now we move to the final bit of the webinar, and we'll be looking at the next steps and implications for research, policy, and practice. We had the slide from you, Laura, on the next steps for the Vivaldi study, and then we'll also hear from Max on the evidence that's emerging and some issues with that. So, Laura, just one final from you on the challenges and priority for Vivaldi for the next 6-12 months.
Yeah,
and
so
I think you touched on it already a bit.
Yeah, so I think the easy thing that we're going to do is to monitor vaccine coverage because we have that data, it's straightforward, but we're going to hopefully add in influenza vaccine coverage too by linking to that data set. We are thinking about how to monitor waning immunity. I think this is really challenging because we can obviously measure antibodies, but we don't know what that means. We still don't know what level of antibody in different groups of people correlates with susceptibility to infection. And it's not antibodies alone, it's obviously cellular immunity too, and the issue of variants of concern. And so we're starting to do some work with the CRIC to look at neutralization against different variants of concern. And hopefully we can build a strategy that lets us monitor all of those things in tandem over the coming months. And that will hopefully put us in a better position to know if and when we need to revaccinate. But I think a bigger question, I think this is close to your heart, Adelina, is about the whole challenge around how appropriate it is to protect staff and residents in care homes versus the negative impact on their lifestyles. And so we still have a lot of disease control measures in our care homes. So we've had periods of visitor restrictions and so forth. And we need to get to a point where there is a reasonable balance between protecting people from infection and not impacting so heavily on their lives. And a very important issue for us going forward is how do we have data systems that enable us to monitor all these things that we need to monitor in our current situation in the pandemic, but also beyond the pandemic. We want to be able to detect emerging infections early so that we don't end up in this sort of situation in future.
Thank you very much. And I think this is an acknowledgement to your colleagues and the funder. Thank you, Laura. So now I'm going to move to Max, and I'd just like to make just one comment, which is how much effort has been made in so many countries to try to bridge all these problems we have with lack of surveillance systems and data in care homes. And there's, I think, a real opportunity to build on the initiatives like Vivaldi and other studies that have been put into place very quickly to try to bridge the gaps and making sure we have we're better prepared for the future. So Max, to wrap up on this generation of evidence on effectiveness of vaccines in long-term care.
Yeah, I just thought in terms of the wider policy or research policy implications. It would actually, so rather than looking at immediately what are the evidence needs as we negotiate the coming months or possibly years of this particular pandemic, to think about maybe what we can learn and what we saw happening in this pandemic and how that relates to other evidence generation in the future. So next slide, please. So I thought it would be interesting to look back really at where we were maybe 9 months ago. So when the first results of COVID-19 vaccine trials were emerging, and they were very promising and really exciting to see. But it was also, I think, very clear early on that they were not really producing evidence for people in care homes. So people who use long-term care, people with who are older and have maybe multiple chronic conditions. And you can see here in this table that shows for some of the major developers of vaccines what the composition of the pivotal trials were for the COVID vaccines that they developed. And what you can see is basically a relatively low share of the population that is 65 years and older, and then even less so 75 and older, 85 and older, and very, very few if any, people with dementia. And that's really strikingly at odds with the composition of the population that bore the brunt of the pandemic in terms of morbidity and mortality. So when we think about, I think over 2020, the share of people who died from COVID who had dementia was 25% in England. And so in comparison to that, we see that a handful of patients really in pivotal trials of COVID vaccines had a dementia diagnosis. So while of course vaccines are not only intended for people living in care homes, I think this discrepancy between who would benefit a lot in terms of stemming the tide for excess mortality and people who were included in those trials and for whom we had evidence on what the vaccine effectiveness, really a key parameter to inform any policy around what measures are appropriate, that discrepancy is really striking. So unfortunately, and really what that means is that's not just sort of a thought exercise about what do we think is appropriate to have evidence, but there is a real cost of missing evidence. And that was clear when we look at how the missing evidence for older people for some of the vaccines was, for example, seen in Germany, where there was a delay of a couple months at least for using, I think that was about the Oxford AstraZeneca vaccine, because the regulatory bodies there didn't see it appropriate to use that vaccine in older people because they said there is no evidence. We don't know whether it works. Similarly, there were concerns about death that were associated with giving the BioNTech Pfizer vaccine in Norway as a possible adverse reaction to giving the vaccines. And so those are costs, and so any lack of trust really in knowing that these vaccines work, those are the actual costs of not producing evidence that is relevant for this population that is in very high need. And unfortunately, that's not restricted to COVID vaccines. Excluding older people, frail people with multiple conditions is very common for clinical trials of pharmaceuticals, and there are reasons for that. There are some reasons that have to do with the efficiency of trials, so basically having a more homogeneous trial population where people do not have comorbidities, do not have multiple other drugs that they have to take, makes it easier or clearer to detect any effects. And it's of course also cheaper to have a clinical trial population that is more homogeneous. But whether those are good arguments to not include those people who would benefit the most from these drugs or vaccines is questionable. There are some, regulatory bodies I think have recognized this problem of excluding older people, but unfortunately, any sort of policies to require or to ask companies to produce evidence have really been empty words. We know that in the US, for the FDA, while they want to see at least data broken down, but for older people, for the majority of new drug approvals, we simply don't have that information. So while that's a policy by the FDA, it's not being implemented. So I think what's very clear from this experience is that unless there are very strong regulatory incentives, regulatory bodies really putting the foot down and demanding that data being produced, but also in the absence of funders, including governments. In this case, during the pandemic, governments have poured billions into developing these vaccines, and they had you could argue, they really had leverage and a say in what or how evidence is being generated. But if those levels are not being used, if regulatory mechanisms are in place to really prioritize generating evidence for people living in care homes, older people with multiple conditions, then we are unlikely to ever get that. There's nobody, other than sort of after the fact, which is what we're seeing now. There are people who would really put a lot of effort into generating evidence, but it's almost yeah, too late to some extent. It's a missed opportunity, I think, in this particular case where we saw so many deaths, to not generate some of this evidence earlier.
Thank you very much, Max. And we're now going to have about 10 minutes for discussion. I just wondered if there's any questions, or if any of the speakers would like to come back and reflect. And I also noticed a couple of questions in the chat. So first going to go around. Jorge, anything from you you'd like to add, any reflections?
Just in the same line that Max just said, I think we have many doubts, and probably those doubts that we are having now are from the beginning of people who were included in those trials. Nevertheless, probably these monitoring efforts that we have seen today, probably they will help to fill the gap of evidence from the beginning of the pandemic. So just to close up, I think that meeting together, sharing data, and showing what is happening in countries is extremely helpful. And just to pop up alerts to share what things have worked before, and rather I know that we have focused today in vaccination, but also I wanted to point out that we still believe that no pharmacological intervention are still really important. So even though vaccination is fundamental strategy, we also have other strategies that are still really important. So that's all for me, and thank you very much, Adelina, for the invitation.
Thank you, Jorge. Now, Amy, you've got about 2 minutes, because we've also got a question in the chat that I think we also need to take back to Laura, which is on booster vaccinations and immunity. But Amy, any further thoughts from you, reflections?
No, I actually agree with both Jorge and Laura's conclusion. You know, lots of remaining questions. That's why we're continuing to do this research. You know, I will point out the fact that a lot of this is knowledge we didn't know 6 months ago. Right. So now I think in retrospect, it seems like, oh, you know, some of these findings are perhaps obvious or they make sense, but it's knowledge we didn't have. And that's why this research is so important.
Thank you, Amy. And please, both Jorge, Amy, come back to us when you've got more findings from both your studies, your countries. And Laura, we have a question. I cannot see the name of the person because it comes out as office, so sorry for the unpersonal naming. But I think there's an office asking about whether people who have been vaccinated have more immunity than those with natural immunity. And I think you can perhaps clarify this a bit.
Yeah, difficult. I mean, with the caveat that I'm not an immunologist. So what I would say is that I have seen data presented that suggests vaccination helps to broaden your immune response. So I think that going back to what Max was saying, one of the challenges is that even if we had done those studies, I completely agree with you, by the way, but even if we had done those studies in those different age groups, we would still have the problem that we now have variants. So what we knew then doesn't apply now. And I think that is our big challenge with all of this, that our immunology says one thing, the data I've presented all refers to March, or a lot of it refers to March. And March and June, July, August, December are not comparable time periods. And so the general feeling is that vaccination is helping you get the best possible immunity. Exactly what the best possible immunity is, I don't think anybody could really answer that question. Definitely I can't. But that's the sort of logic that is underpinning all of this. But yeah, maybe you should get an immunologist back, Adelina, to actually answer that question properly.
That's a good suggestion. Thank you. And there's another question in the chat, so I'm just working the way back. It's actually for Jorge, which is on the delivery of free personal protection equipment to to homes. And Jorge, I know you've got a paper looking at the response and the barriers and facilitators to response in care homes. So feel free to put the link as well. But Jorge, would you like to answer?
Yes, of course. Thank you, Elena. Yes, this is a really important issue. Access to PPE has been pointed out by managers and caregivers as a key issue to implement the protocols and basically the whole strategy. The paper that we have in LTCcovid, it highlights the importance of that, and also highlights that those we interview didn't have any issue with access. So access has been not a problem in general, because it has been delivered by Senama and the Ministry of Health. The first wave of interviews were of facilities that were public and non-for-profit facilities, which were the first priorities in the strategy. But later on, informal facilities were prioritized and given PPE. And we do have an ongoing paper in LTCcovid that in which managers from those facilities were interviewed as well. So a really important issue. So thank you for pointing that out.
Thank you very much. And I think that's probably as far as we can go today. So I'd like to thank the speakers. Thank you very much for all your work. It is extremely valuable work you're doing. And thanks to these, the governments are able to hopefully do better for people who live in care homes. And we're also going to be able to strike a better balance between infection prevention and control and freedom for the people who live in care homes as well. We need, the more we understand how vaccines work, their efficacy, and the more we will be able to also feel confident about each of the steps. And of course, situation keeps changing, and we do need this research to keep informing us. If any of you would like to present at a future event, please let us know. Can reach us through LTCcovid, through Twitter, I think, and put comments, and also let us know about future events. We have one more webinar in July, which is looking at long-term care systems in France, Italy, Portugal, and OECD. And then we'll come back in September again. We're going to take a bit of a break during August, as some of us will be having a bit of a rest. So thanks again to all the speakers. We will be sharing the video and the slides, and we'll also put the links to all the papers that have been mentioned during the presentation. Thank you, and have a good day, good evening, wherever you are. Thank you very much.